Tired of this same old drill and repeat in motor speech therapy? What if there was a better way, one that actually connects with what matters to your clients? I'm your host, Sarah, and today we're shaking things up with Carolyn Baylor, the brilliant mind behind the framework for participation-focused intervention. She's sharing practical, real-world strategies that could change your therapy sessions tomorrow. If you're ready to ditch the rut and make your work more meaningful, this episode is for you. Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Dr. Carolyn Baylor, an expert in the area of motor speech disorders and communication participation. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Carolyn, I'm so excited you're here. Can you get us started by sharing a little bit about yourself and how you're involved with motor speech disorders?
Well, thank you so much for the invitation to be here. It's an honor to have this opportunity to speak with you and our community. So a little bit about myself. I got started in my career really in clinical adult medical speech pathology, spent several years practicing full-time. My populations were part neuro, but my clinical lab was really voice, head and neck cancer, otolaryngology. When I came back for my PhD is when I really got connected with Dysarthria. And I have to really credit Kathy Yorkston for that. I had the great honor of having Kathy as both my master's thesis mentor and my dissertation mentor. And so, as many of us know, she really had just a world-renowned reputation for her work in motor speech. And I kind of laugh because the two of us will kind of have a little bit of a tug-of-war at times, because when it came to things like what population should we work with, she, of course, wanted to do motor speech, and I kind of pulled towards the voice direction, and we'd compromise on what's a neurologic voice diagnosis, and that's kind of where we land. I also want to mention, though, in terms of involvement with motor speech, I want to mention Megan Darling-White, who co-wrote the paper with me and really helped open this up to think about pediatric populations, as well as Julie Case, who's also helped me in some of this work.
Fantastic. And I know I was lucky enough to hear you talk about this at an ASHA convention. You authored one of my favorite articles, and it is about this framework for participation-focused intervention. So when I read it, it just really sang to my heart, my clinical heart, because I love life participation, and it made so much sense. Why don't we just start by talking about maybe just the background, like what prompted you to develop this framework? Were you noticing like a certain clinical challenge? Like what was like the first step to doing this?
Yeah, I think I need to point to both a clinical motivation and a research motivation. And my clinical motivation really comes from my own clinical work. And I'm thinking of one of your prior guests who mentioned the term like a clinical irritation, something that just didn't sit well clinically. And for me, I think I have to take it back to the voice clinic when I would be working with my voice clients. Now, this is admittedly a couple decades ago when, our training was different, our work was different, and there was not a lot of focus on patient-reported outcomes. And so, we would do our assessments that were about speech and voice function, which was okay. And we would write our goals about speech and voice function, which was okay. But then we'd get into therapy and we would work on speech and voice function, which was okay. But then a lot of us gravitate to doing more. We're really talking to patients about what's happening in their lives. We're problem solving with that. Let's figure this out. Let's find some strategies. Let's work through this with you. And then we would come to writing the discharge summary. And when we go back to trace back to our intake data and our goals, all of that was speech and voice function. So that's what we'd put in our discharge summaries. And it's like, where did all this other work that we did on real life hoping, participation, all of that was invisible. And it's critical work to do, but it doesn't show up in our goals and our documentation. And so it's just invisible. And I really felt like that was kind of cheating our patients. And it was definitely cheating our profession to not be able to communicate to all the people we need to communicate with about the value and what we do. So that left me frustrated clinically. And then when I came back to the research realm and started doing a lot of qualitative interviews with people living with a variety of communication disorders, and I would interview them about their experiences in speech therapy. And I was not their clinician, so could really step back and say, what did you think? And I heard a lot of disappointment from people that speech therapy was more about what the clinician wanted to do, not what they wanted to do. People would say the clinician came in with their own agenda, but that wasn't really what I want. And just putting those together, made me think we do great work, but we need to be sure we're doing that great work, and we need to make it evident in our documentation, our assessment, etc.
Wow, that's awesome. That's really resonating with me because I kind of felt the same way, like we aren't getting credit almost for the work we're doing, right? Or like, oh, I don't know if speech therapy works or, and it's like, oh my goodness, we need some ways to show what we're doing because when you have those one-on-one moments with clients, we know it's working. And I resonate with that clinical irritation. So why don't you give us then a high-level view about what are we talking about with this framework for participation-focused intervention?
Thanks. And I think I might just actually jump in with maybe a sample case and a goal, which is maybe not starting with the formal introduction of the framework, but I think maybe a practical way. So let's just take a hypothetical case of a gentleman who comes to our practice who's recently had a stroke and has dysarthria. And I'm going to keep it really simple with just dysarthria and we know a lot of our stroke patients have more complex things going on communicatively, but let's just stay with dysarthria. Through the intake interview, we learn about him. And maybe as my intake assessment, I've done a patient-reported outcome like the Communicative Participation Item Bank, which I will refer to as the CPIB to keep it shorter. And on that, maybe we noticed that on the item about difficulty communicating in small groups, he's indicating a lot of problems there. And as I visit with him about that, about, his life, I learned that he is really struggling because a big life situation for him is maybe family dinners, big extended family dinners that happen several times a month. And that's a big quality of life situation for him. So when we go to write goals, I think a traditional goal that we would write that we might think is participation-based is a goal that says, to promote participation in family dinners, client will demonstrate 90% intelligibility in naturalistic conversations, et cetera, et cetera. And we know how to finish that goal. Now, I'm going to challenge us to write a different goal. And the different goal would be something to the effect of, the client will report satisfaction with participation in conversation in extended family dinners at a level of 8 or higher on a scale of 0 to 10, where 0 is not satisfied at all, 10 is extremely satisfied. Now, let me compare those goals a little bit. The first goal we always write, it's not a bad goal at all, but it's not a participation goal. It's a speech intelligibility goal. Even though we put that little clause in front of it that says to promote participation in, that's really just stating the motivation of the goal is participation. But the actual goal is that the client will achieve 90% intelligibility. And the problem with that goal is if the client achieves 90% intelligibility, even in the situation of the family dinners, we might say, great, our job is done. The goal is reached and, we move on, only to find out later the client actually isn't really participating in family dinners. And we think, well, we thought we did our work. We got the 90% intelligibility. The problem is we didn't measure and address the other things preventing communicative participation, like maybe the family, is supportive, but they're a really dynamic family. They talk quickly, they talk over each other. The patient can't break into that. Maybe even though his intelligibility is functional, he still may be really self-conscious about his speech or not very confident about engaging. So he's not participating, and we totally missed it. So if we write the second goal, the client will rate their satisfaction or their involvement or whatever we want to call it at a certain level. If we keep going back to that goal, it reminds us our job isn't done until we are sure the patient truly is engaging and participating. And so a participation framework is about writing that broad-based goal and then analyzing what are the pieces that we need to address to make sure the patient is really participating. Yes, it's the intelligibility, but it's also specifically working on environmental access. It's specifically also working on the coping, the confidence, whatever component we need to work on to help them participate in the communication. That's what we'll do to get to that point where we can document it's going well in overall participation.
This is really, it sounds simple. Like I'm just imagining, a different profession listening to this. And it's like, oh yeah, that makes sense. But for our world of speech therapy, it's such a change because it's like it doesn't matter as much like how they perform in our speech therapy session, but it's like outside of the session. And just that, it makes so much sense to me. So I love it. And let's get into like a few more of the details with it. So first of all, in the article that you wrote, I believe it's kind of like motor speech examples in the article. So let's talk about the ideal clients that we might want to think about for this approach. What are you thinking about for like what clients you would use this approach with? Or maybe even if we're thinking from the SLP perspective, are there like certain settings that SLPs would be working in that you'd recommend, like this would be a good way to think about things?
Not to be too, overstating this, but I really think this is for every single client we can work with. It seems to naturally fit, and I think I talk about it most naturally in like an outpatient setting where you have time to really dig into these details and work over time with the client. And also, it really gravitates towards adults because we're doing a lot of problem solving together. But we need to think about how we can adapt this for everybody. And let me give you two examples. One is for pediatrics. Of course, we are very concerned about the life participation of our children in their life domains. And in those settings, a lot of this detailed problem solving and goal setting might be more with the parents, the teachers, the adults in their lives, while we're also paying attention to how our little ones are doing. But this absolutely is appropriate for our pediatrics. I also want to specifically talk about a setting that may not come to mind right off the top of our head, but that to me is acute inpatient. We often might think, oh, we're not going to work on life participation for acute inpatient because they're only here with us for 2 days or 6 days, and then they're moving on. And we're not really going to talk about, addressing life outside of acute inpatient while they're here because it's too dynamic, things are moving too quickly. But what I want to really advocate for is this work should be about, first of all, participating in our patients' immediate communication environment. So if they are an inpatient, the first thing we should be working on is how are they doing with accessing communication right now for their immediate healthcare today with their healthcare providers, family, etc. And I think a little too often we kind of abandon our role as the communication specialists and the communication advocates in inpatient settings when communication is so key to healthcare safety and healthcare advocacy that the very first thing we should be working on is how are you doing participating in the communication with your nurses, your other therapists, your physicians, etc. So really, I think any client we can pause and say, this probably is relevant in some way.
Yes, and I totally agree, because I've been using your work now for a couple years, and I feel like I'm like, this makes sense for so much more beyond just my motor speech clients. And then even your thought about acute care, I did acute care for about 9 years, and I have to say I have like a lot of like reflections I've done about it, because this was before I got into person-centered care, and I just think, what would the rest of that person's medical journey have been like if we set the tone in a different way in that phase, right? Like, imagine someone with aphasia, like right away, if you do this more participation approach, you're showing them the role of speech therapy, you're empowering them about like using skills and strategies. And I know that's not usually the way things, we tend to use our time in acute care. So I think I agree with you completely. So let's talk about then when we're wanting to do this approach, and some people listening may have dipped their toes in. Some people, this is probably going to be a whole new way of doing things. So I thought we'd just kind of walk through the clinical journey, starting with the assessment. What type of information are we going to be looking to get in the evaluation time if we do want to be more focused on someone's communication participation?
So in the assessment, we are going to focus on both qualitative and quantitative research data. See, my mind goes to research, but with the clinical case, we're kind of researching what's happening with our client. And I'm going to talk a little bit more about the quantitative data, because I think it's natural for all of us to think about, I'm interviewing my clients, I'm collecting anecdotal information about their life, I'm doing that, great. But we also know for our baseline measures, for our outcome measurement, for our goals, so many times we are pulled towards quantitative data. We need to put things in numbers for a lot of our report readers who like numbers. So I'm going to focus a little bit more on. And I think about 2 levels of measurement. So in my initial intake interview, I would really try to do a patient-reported outcome like the CPIB or something similar, if you have a favorite one, that will quantify something about the person's experience with communication in their daily life. And I think that type of questionnaire is great also for a launching pad for a conversation with them about, how are they doing when we see their scores on the questionnaire. And then we can take that questionnaire and kind of use that score as essentially a long-term goal. We can document this is where our client started with their overall participation. And we might not come back to that questionnaire frequently. We might save that towards a discharge or a big progress check where we can say their score changed from this to this.
Can I jump in here about CPIB? Okay, first of all, I've been calling it the CPIB. So now I love that there's an even shorter way to say it. CPIB. Okay, that's the new thing. We're going to say CPIB. And then I just want to give you all the credit here. You're the author of the CPIB, aren't you?
Well, I am on the author team. Kathy Erkson really started it, and I joined to do my dissertation, and our team has continued it. Yes.
And then I thought, like, it's available digitally or online now, right? So maybe we could just stick a link in the handout for this episode. So just in case people aren't aware of that, we can share that too, because that's pretty cool. I was into it when it was just like the printable, and now it's available kind of through a website. So that's pretty cool. Okay.
Yeah. And I'll just mention that website link is actually for a computerized adaptive version. And I won't get into all the psychometrics behind it, but basically what it does is it offers the opportunity to tailor the assessment more to the client. And so often you can get through it in fewer than the 10 items that are on the paper short form.
Amazing. Good. Okay, we'll definitely include the link then. So that makes a lot of sense, like using more of that patient-reported outcome measure for kind of like long-term goal, or like what's going to be your impact over the course of therapy. And then what do you think for like short-term goal type of stuff?
Yes. So then when we really dig into what are our therapy targets going to be, and we want to measure baseline on those targets, we would pick with the client the specific situation or situations they want to work on. And I'll focus just on talking about one situation as an example, but you could replicate this if you wanted to target multiple situations with the client. So let's go back to our example of the gentleman who wants to focus on participating in these extended family dinner conversations. I would take that specific situation and get a quantitative measurement of how he feels his communicative participation is in that specific situation. And that's where I might go back to an example of like a goal attainment scale or a Likert scale or a visual analog scale. I kind of mentioned one earlier, just having him rate his satisfaction with his communication in that situation on a 0 to 10 scale. And always define your anchor. 0 is not satisfied, 10 is completely satisfied. And so if he says, oh, I'd rate my satisfaction or my communication in that situation as a 2, now I have my baseline measurement in that specific situation. And what I hope as we go throughout therapy and I do periodic probes as we work on that situation, I hope to see that his rating goes up and up and up, which helps to capture some of those small changes as we go through therapy. And it might take working on a few situations before we see the change in the CPIM, the big overall measure.
Yeah, that makes sense. So do you find when you're talking with clients, like to pick a specific situation, how does that process go? Does it feel like pretty easy for like, because you're talking in maybe a different way, is it easy for clients to like identify like, oh yeah, like the family dinners or what, whatever, or what's your experience been like with that? Because I know some SLPs feel like they're in settings where the clients are just maybe don't come up with their own goals as much.
Mm-hmm. Well, and I think you bring up a really important point that when it comes to patient-centered care and putting our patients a little bit more in the driver's seat, there's going to be a really wide range. Many clients and participants I talk to really like this idea, often saying, what are your most important conversations? Or, what is it that's bothering you? Or just tell me a little bit about how some situations you've been over the past week or so. We can phrase that intro certain ways to gather that information. And, rarely do people get stuck on, I don't have a situation that, I don't want to improve. We all know that we have patients sometimes who just, when we say, what do you want to work on? They say, oh, you're in charge. What do you want to work on? And so sometimes we might have to guide that a little bit more. But I think we can always, through some gentle conversations, find some situations in the client's life that are meaningful and relevant to them that they want to work on. I have a fun vignette, if I may go in real fun with the client. Was visiting with him. This is a gentleman who had multiple sclerosis and, multiple communication challenges related to that. And this was actually a research participant. And when I was visiting with him about his experiences in past speech therapy, he said, well, he didn't really like it. It was kind of a little bit of like see Dick and Jane run. And for a cultural reference, that refers to like kindergarten and first grade reading books, see Dick and Jane, that were really popular when this client would have been a kid. I don't think we have them this day and age, but it was his way of saying it was just, really elementary and not very interesting and childish. And I said, well, what would you have wanted to work on? And he said, well, at the time I was single and I was having trouble picking up women at the bar because of my speech. And I would really have liked to practice pickup lines. And I was kind of taken aback. And then I thought, well, why not? Why not? Mm-hmm. If that's what somebody wants to practice, why not?
Honestly, I would be so thrilled to have that be what I was doing in speech therapy for the day. That would make it so fun and interesting.
It does make it a lot more fun for us. Yeah.
Yes. Oh, that is it. That's an awesome story. So when you're when we're talking about participation, I love how you painted the picture of really focusing on holistic goals. We're kind of starting with that big goal and kind of working our way from there. But here's my question. So we're coming from measuring like all the impairment type of goals or like intelligibility and that sort of thing. But in your framework, we're focused on, participation and the environment and that sort of thing, personal coping. So where do you land with the types of goals that we're setting? Are we throwing out the intelligibility goals? Are we focused more on just like, okay, what's your rating on how satisfied you are with your participation? How are you kind of balancing all of those features in our field?
Thank you so much for asking that. I think this is a really important point to me. I am a little concerned that some people think about participation-based therapy as opposite of impairment-based therapy. And you're either doing participation-based or, you're doing kind of more traditional impairment. I don't see it that way at all. I see it as an and. To me, participation-based intervention is an umbrella. And under that, we are going to put anything and everything that's appropriate to work on with our clients. So if there is an impairment-based sub-goal to that, we should write that goal and we should work on that. So with our stroke client with dysarthria, recent onset, still within a very good prognosis for improving motor speech, you bet I'm still going to write a intelligibility goal under that, and I'm going to work on my clear speech strategies or any other approach that's going to improve their speech intelligibility. We are never going to abandon working on the impairment when it's appropriate for the client. But with a participation-based approach, we then say, and in therapy, we are going to measure, write goals for, and really work on environmental accessibility, coping, anything else. So it's really an and that incorporates everything. It is not an opposite.
Yep. Okay. That makes a lot of sense to me. And thanks for clarifying that, because that's a question that I hear from people too. So it's great to hear from the expert how you're thinking about that. What might then... So we do the assessment, we kind of have our long-term goal, we figure out the short-term goals. I'm going to just actually ask one other question about the short-term goals. I think the environment goals can be really tricky for SLP because that's not really in our like past wheelhouse other than, turn off the distractions, like make sure you're not talking when the TV's on, like. Other than that, like, can you just share with us, like, what are some environment type of goals that you think about when we're trying to support somebody's participation?
Right. And I think you're right. The environment is where we need to do quite a bit more work. And to help us with measuring that, I think we can still stick with a lot of our non-standardized assessments. If I may put in a teaser, we are working on a new patient-reported environment measure that, hopefully we can get that data analyzed and get it out in the coming months. So more support coming. But to set a goal, 2 examples, let's say our gentleman in the family dinner conversations, we might write a goal to say, in the next 4 weeks, the client will implement a minimum of 2 strategies to educate family about his communication needs. And that kind of speaks to the fact that we can't control everything in the environment and ensure it's going to get better, but we can help our clients develop and implement strategies so we can meet that goal, by doing that. Or sometimes we can write a goal that might say, again, on that scale of 0 to 5, the client rates the extent to which, family interrupting him is a 5, and we're going to try to reduce that to a 2 or something. So we can write that type of goal to try to say we've actually made progress reducing the barrier. And then I think a big important thing in the therapy sessions is we need to move away from this idea of we have a long list of strategies, we hand it to the client and say, implement it, and our work is done. Because clients are not going to implement it. And I think we know that. And it's not they're lazy. It's not that they don't want to do it. It's oftentimes that they don't know how or there's too many barriers. It's like, yeah, I could talk to my family about being more supportive, but what do I say to them? And I don't want to insult them, and I don't want to inconvenience them. And so I think what we really need to do is make that therapy, which means taking time in your therapy session to talk with your clients about, what might be the challenges with educating your family. How would you like to educate your family? Let's brainstorm that. Do you want to talk to them about it? If so, let's make up the talking points together. Do you want to send an email? How about if we write that email together? Do you want to talk with them in the next family meeting? Let's practice that here. Let's figure out exactly what you're going to say. What strategies would you like them to use? I've heard people use, a signal strategy. I'll put up my hand when I want to talk, or we need to spend time with our clients actually breaking that down and analyzing the problems in detail and helping them build up the exact plan, and then practicing that plan in therapy until they say, yes, I am ready to do this. So that becomes therapy.
Awesome. Thank you. That's a lot of good specific info. Okay. We are now going to do the wild card question. So get ready. It's wild card question time. Okay, Carolyn, what is a hidden talent or skill you have that most people don't know about?
I really wish I could come to you and say there is a hidden life of Carolyn Baylor that is just wow and amazing. And, I think in all honesty, like so many people, I am a mom making my way through daily life, work life, home life, and, there I am. When I get time and have people to bake for, I do like to bake. I have a couple really favorite family recipes: caramel rolls, cinnamon rolls, dinner rolls.
Amazing.
So maybe those are my hidden recipes and handed down from family. I don't think there's anything really glamorous about me.
It does not have to be glamorous. I love that. That's those sound delicious, and I love to bake myself. So yeah, awesome. Okay, thank you for that. So just like to know the person behind the expertise here. Okay, so back to our framework here. Let's talk about then our therapy time. So we've done, to me, the hard work, quote unquote, hard work is the goal setting. And then we've talked about all that. Once you have the goals, then the intervention comes. So can you just talk about what's intervention like then?
And some parts of intervention may be very similar to what we always do. Some may be a little different. But if we have kind of spent that time figuring out with our clients, so what are the issues that are making it difficult for you to participate in these family conversations? It's probably multiple issues, and we are going to spend time in therapy working on all of them. And so I would divide my therapy sessions up that way. So again, maybe we spend some time working on the impairment, the intelligibility. Let's practice those clear speech strategies, but let's make sure that practice is using the actual vocabulary, terminology, conversations that the client uses in that real conversation. So we're going to throw out the random word list, and we're going to say, so tell me your kids' names and your grandkids' names. I want to practice saying those names. What are some of the topics you like to talk about? Oh, you like to talk about, football games. Okay, let's practice talking about football games. What's your favorite team? Let's practice talking about that. And some of that is practicing those in more of the drill format to get those strategies set. And part of that can be kind of the role playing. And then I say, okay, great. That's some good practice. Now let's spend some time in therapy with some of the other problem solving. And that's where we would turn to some of the things like I just talked about, spending time talking about the strategies for environmental accessibility. What are the barriers in the environment? Let's really dive deep and problem solve. And the coping piece, the counseling piece. How are you feeling about all of this? Do you feel ready to do this? If not, kind of how are you feeling about that? And I think we're well into understanding our counseling role. in speech therapy. So we pull that in. And then the next session, when that client comes back in, we need to start with, how did family dinner go this week? And let's break that down and let's analyze it in detail. Let's celebrate the things that went well, the things that didn't go well. Let's say, okay, let's talk about that. Let's problem solve that. Do you want to try that strategy again next week? Should we change the strategy? So it's really breaking that down in detail. And then if we are working with the client on a second situation, like maybe they also have a goal of, I don't know, maybe they volunteer in their religious community and maybe lead some, lead a portion of a worship service or something. We might say, okay, now let's spend a little time talking about that other goal and kind of going through the same routine.
Awesome. Yeah. And I like the example of like starting your next session asking about it, and because it just makes the link for the client. And I went through like a really dramatic shift for kind of all of my care, but like even like my motor speech clients, like for so many years, I would be like giving the worksheets, giving the drills, like the most boring homework ever. Like I felt bored giving it to them. I can't even imagine what they thought at home. And, they wouldn't do their homework, no surprise. And then when I like made that switch and it was like, oh, you were going to like practice, like, talking to your grandson, like, how did it go? And then like, I noticed like the thing clients would say is like, oh, it was just like we practiced. Like that's like my new favorite thing if clients say it. So I'm like, oh, good. Like I did just what I was hoping. Like it wasn't about the speech therapy time. It was about life. And they understood that. So that's an awesome example and something that's so small, but I think it really matters to clients. So one thing I wanted your perspective on is when you're focusing, let's take this guy, he has dysarthria after a stroke, and you're spending your time talking about like this specific situation, like the family lunches. So do you ever feel like patients or any other stakeholders give you pushback because you're focusing on just like a situation, like let's say that just happens once a week? I know I'm asking that because I think as the SLP, we maybe like feel like a weird pressure about that decision because we're like, well, they're like, they have to talk all the days, but I'm just like working on this situation. I just wondered if you had any like ways to think about that or talking points about that issue.
Yeah, I think that's an important issue. I think one of the challenges we've had in our discipline is by trying to be so broad and applicable to everything, our strategies end up being applicable to nothing. Because I think we all know each communication situation is different. And so you cannot give somebody a really broad strategy and then expect them to fit it to different situations where it needs to be tailored. So I've never had clients balk at this because it's so practical and real life to them. I do think it's the clinicians having us think about it differently, but I think about it in terms of generalization, which is something we know very well. The thought being you start working on one or two specific situations, kind of whatever your client can manage, and you're going through these practices of let's identify barriers, let's problem solve ways around, let's implement, let's problem solve them again, let's find success. And when that situation starts getting better, okay, now let's take that framework and let's apply it to another situation in your life and work through it. Okay, let's apply it to another situation in your life. And we all know that generalization happens. So what we are waiting for is that point where the client comes in and says, this week I was in this other situation and I remembered we had talked about this strategy and I used it there and it helped. So the idea is that we are helping clients to become their own self-advocates, their own problem solvers, that they can then go into any situation that they're struggling with and say, oh, I know how to work through this because I've done this in 2 or 3 situations in therapy. And that's where I kind of think generalization is it.
Yes. Oh, that is awesome. Yeah, that would be another thing you definitely want your clients to come back and say, right? That's awesome. One of the things that I had to take some pressure off for myself, like when we're thinking like, okay, what's your most important conversation or starting it is just like, let's start with one. And it's like, it's okay if it's not like the tip top, but because I think it just helps clients start to understand like what the point of therapy is. And so sometimes just by starting with one, it doesn't have to be like the most magical need ever, but it is like a way to start the journey. And then I do feel like clients will start to bring up like, oh yeah, like, well, I'm getting my nails done every week. Like, can we work on how that interaction goes or like things like that? So.
And I think that is a good point because a lot of times, especially in outpatient therapy, our patients may be saying, oh, I'm aiming to get back to work, or that really big thing that's a distant out. And that might be their most important to them. But we want to start on something more immediate that we can work on right now. So what's, another important one that's, kind of more to the point for today.
Yep. Awesome. Okay. So if this has been such a good conversation. I'm just loving all of your examples and insight. So if we were going to do maximum impact here for the people listening, what would be your top 3 actionable takeaways for clinicians to put into practice?
Yeah, so let me think of kind of 3 places to start if this is a little bit new to you. And this might kind of be summarizing things we've said. But I do think if you are not used to doing this, is start by asking your client, just giving you some examples of how things have gone in their day-to-day communication, since you've seen them the last time. Give you some examples of 1 or 2 situations. We just need to start asking people about real life and spending some time visiting with them about real life, not just kind of saying, how is it going? And then tossing that aside and back to the worksheet, but following up on how it's going.
That's not like a nicety. It's like
right.
Part of, it's like shaping what we're doing.
Right.
Yep.
Right. I like that. It's not the nicety, establishing rapport. It's like, oh, this is what we're actually going to work on. And then I think start bringing in those like mini patient-reported measures as those little measures along the way to kind of see how people are feeling and how things are changing. So whether you use a visual analog scale or a Likert scale, the 0 to 5, the 0 to 7, whatever format of that, but just something like even within a session where you may be practicing an advocacy strategy. And at the beginning, people are like, I don't feel very confident with that. I'm going to report that as a 1. And then, you keep practicing it, role-playing it, problem-solving it. And a couple of sessions later, you're checking in. How do you feel about your confidence using this strategy? And they're like, oh, I have a 4 now. Great. That's a data point that you can put in your, in your SOAP note, to say, hey, we're making progress here. So deal with real life, start to measure it with some quantitative ways. And then I think the third thing I want to mention, I think is really important, especially for clinicians who may not feel as confident with this, is a lot of times I see, especially our beginning clinicians, spend a lot of time and stress starting with a blank page for planning their lesson plan and thinking, how am I going to put together a therapy session that addresses my client's goal of, say, these family conversations at mealtime? Like, they know what the situation is, and they're thinking, how do I start from scratch to create something out of thin air that's going to address that? And I would say completely reverse your thinking and say, we're starting with the situation of these family conversations. We are good analysts. Take that situation and analyze the real situation and break it down into the pieces, the components, what's creating the problems, and then take those components and break them down into the little steps. So whatever the barrier is, the environmental strategy or the coping strategy or whatever, when you identify that, we know how to do sequential hierarchies. We know how to get something down to the level the patient can do, and then practice building that back up into now they're ready to enter back into that situation. So don't start with a blank page, start with the problem and break that down into concrete steps.
That is awesome advice. And we haven't said, but your article, the supplemental materials have examples of this and just kind of lead you through step by step how to do this. So we will also include the link to your article so people can quickly find that as well. Okay. Do you want to share any last clinical examples? You've done such a good job sharing in every question here. I want to just offer you the opportunity if you want to talk through any other case application for that.
Let me give you another example, and I think you touched on this earlier when you say one concern we have about clinicians is what if a situation that's really important to clients is something they don't engage in very quickly. And I think an example that we've probably all seen is an adult client who comes in and says, my kid is getting married in 4 months and I want to give the toast at the wedding type of thing. There's only one of those events. We can't measure it over time. But I think what we would do then is I would create my goal to be client will report their readiness to engage in the situation as a, whatever. And then we're going to work on getting them ready for that situation. And so we may measure the outcome as my client felt ready. And we can't control how the actual toast goes in the situation. But if we did everything we could to get them to the point where they feel ready and empowered and equipped, our job is done.
And I love the permission you're giving us all to use just the very simple 1 to 10 scale, but we can customize what question we're asking to the situation and to the client, right? The readiness to participate. That's wonderful. So this has been so delightful. I just could listen to this stuff all day. Thank you so much for your work in this space. And I can hardly stand to know you have a teaser new patient-reported outcome measure coming. So please let us know when it's ready and I'll help blast it out there. To wrap things up, what final words of wisdom or inspiration would you like to leave with the audience?
Yes, I think what I want to really emphasize, if this is a new way of thinking for clinicians and they maybe feel a little, overwhelmed or, oh no, or how do I do this? I want to emphasize that I think all of us in this field are really creative, really good problem solvers, really good flexible thinkers. And this type of therapy calls on that. And I think at times we need to just quiet the part of our brain that's what do I do? What do I do? What do I do? And open the part of our brain that's about listening, about tuning in, and about just thinking creatively. And I think you will find this is probably a lot more intuitive and easier, and as you said, more enjoyable than struggling to come up with a lot of kind of stilted artificial activities. So I just want to say, you're all empowered and ready to do this. We just have to kind of embrace that part.
Oh, wonderful. Awesome note to end on. Thank you so much, Carolyn, for your insight, your time, the work you're doing in this space, and the clinical takeaways related to dysarthria and life participation.
Thank you so much. Loved being here with you.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.